Hi, and welcome to week 6 of Nursing 259. This week we will be talking about the teaching and learning, specifically some of the things that you might need to know to do your teaching and learning project due at the end of the month. Cheryl and I have already assigned topics to individuals in the 259 class, and these next lectures over this week and next week will help you complete that project. So our objectives for this whole week will be to recognize the characteristics of effective teaching, and as well as to explain the assessment of learner characteristics and needs. For this video presentation, we will only be talking about the health literacy as well as patient adherence. The other items we will be talking about in class this week. There's a couple of readings this week. I strongly advise to read chapter 1 and 10 in Falvo. There's very good information on both of those topics, and they'll give you a broader sense of the topics that we'll talk about in this video. So at first, when we talk about adherence versus compliance, it's not really a matter of just having a word versus the other. A lot of people would say that whether a patient is adherent to their plan or compliant is really just a matter of semantics. But some might argue that it's more of a power struggle. Is it really that they cannot or that they will not adhere to the plan that we have? And I guess it all depends on how you look at it. Some of the things that Falvo talks about in specific, it would be that compliance kind of assumes that the patient has control over their outcomes, and it might be a case that the patient just is unable to or unwilling to use the plan as written, or maybe they just didn't understand. Adherence makes it sound like it could be, it's really the nursing and medical responsibility to make sure that the patient has all of the information that they need, and that informed consent is also implied, that they understand what it is that's being asked of them. So why does adherence matter? Why are we talking about it this week? Well, back in 2008, Medicare was altered based on the Affordable Care Act that came out, ACA, and as a result of that, Medicare had been tasked to, instead of paying hospitals to pay for every hospital admission and for every procedure, that hospitals were going to be paid based on outcomes. So if the patient's outcomes were not good, it was implied that hospitals should have done something more, or maybe they weren't following evidence-based practice. So they set up some guidelines for a 30-day unplanned readmission and death procedures, as you see here on this web page. So there's 4 diagnoses for patients that should they be discharged from the hospital, we say they're good, they leave, they have heart attack, heart failure, pneumonia, or a hip or knee replacement. These patients are not expected to return within 30 days. It's assumed that we've stabilized them to the point where they shouldn't have to return. Now, further down this page that you can't see on this because it's just a screenshot, they'll also be talking about a 30-day death measures, and those are also with those 4, the heart attack, heart failure, pneumonia, and hip and knee replacement. So if any of those happen within the 30-day period, the hospital is penalized for not doing enough, and so their outcome was not as expected. So some of the things that may be interesting to you is that 58% of emergency room visits were found to be directly related to non-adherence. So a patient didn't understand, they didn't follow their medication, maybe they took too much of a blood thinner, maybe they didn't take antibiotics as prescribed. So I think that's very interesting that so many of these emergency room visits happen because patients couldn't follow or were unable to follow directions or plans. Generally, non-adherence across the board for all patients, those that may or may not result in an ER visit, is somewhere between 25 and 57%. But it's really hard to track the actual numbers because they don't come to the emergency room. So these are just from surveillance that we do. So what are the consequences of poor adherence or non-adherence? Well, obviously, for the patient, there's some problems, and this can affect their emotional state, their health beliefs, social groups, feeling of disease and inadequacy, and the socioeconomic factors that can just cost them a lot of money. For the community, this can be a problem because this is how the patient, the whole cost of their stay may be reliant on individuals paying for insurance premiums, maybe a care facility or families may be asked to chip in to help with this patient and pick up kind of the slack for what the healthcare didn't take care of, or maybe even the patient didn't take care of it. And for the healthcare system, this is an issue because frankly, healthcare costs a lot of money and a lot of resources. And whatever resources we give to someone who was unable to follow a plan obviously gets taken away from other things. So all of these things, the treatment factors, the interaction with the system, and personal factors are all things that contribute to whether a patient is able to adhere or be persistent in that adherence. So what does it mean to be non-adherent? So this can look like a lot of different things depending on who you ask and what side of the patient that you may be on. Maybe it means that they can't keep appointments, but maybe it's not because they don't want to go. It could be fear. It could be not being able to keep a calendar very well. Maybe they have visual problems or hearing problems, but it could also be that they live in an impoverished area, maybe in a rural setting, and they can't make it to an appointment. These patients could be non-adherent because they're doctor shopping. Maybe they're looking for an answer from someone, or maybe because someone didn't give them enough compassion. They're looking around for something that they didn't find in the first place. So what can happen is that people are left out of that loop, and maybe someone has started a plan and other people have started a plan and there's duplication in services. Medications is the obvious one that we think about. Just being able to understand the directions. We tend to explain things in our language, but that isn't always what the patient understands. For instance, if we ask somebody to take something twice a day, they often don't know what that means. Is it 2 in the morning, 1 in the afternoon, 1 in the evening? It kind of depends, and it's really not unusual to have patients not be able to follow medication, and sometimes it's just side effects. Dietary non-adherence, this could be, if we have them on a low sodium diet or a low fat diet, this may be very difficult for patients. Lifestyle, everybody knows that we should get enough exercise and activity, but sometimes pain and sometimes motivation, depression could affect their ability to maintain that. Treatment regimens can be terribly complicated for patients, and again, if we're using our language instead of theirs, they may not be able to understand. Preventative health practices such as screenings, immunizations, things of that nature. There's a lot of misinformation out there. Maybe people think that they can find the information on the internet, but some of the information, as you might know, is not accurate. So we have to be looking for that. And a lot of this just comes down to health literacy. That's the bottom line, and that's what we'll be talking about on the next few slides. So, the U.S. Department of Education defines literacy as having 3 components. So what they say is that there should be prose, and that's that patient's ability to find information that's relevant and using that information to improve their health. Document literacy, that's their ability to use graphs, maps, tables, like the instructions that are written on the back of over-the-counter medications. And quantitative, just being able to do everyday math. If we ask them to take half of a tab 3 times daily, they may not be able to plan that very well if their math skills are not very good. So literacy includes understanding also how to navigate healthcare. You know, we're really good about putting all the signage up in hospitals that say cardiology or radiology or nephrology. Patients don't always know what those words mean. So it's important for us that we use signage and language that patients can use as well. 25% of the US population is unable to understand the written materials that we give them. That's quite a few, 1 out of 4 patients. And that's probably higher depending on where you live. And just because this is a key point that I want you to take, and I'll be reiterating this through the next few weeks, just because you told them, just because you gave them the information, doesn't mean that they received that information and understand what to do with it. So that's very key. So some of the myths about low literacy, a lot of people have their ideas about what a low literate person might be. Some may believe that these people are uneducated, and that's just not true. I am highly educated, but I would have difficulty understanding somebody that was trying to say, well, you're a nurse, you understand, and I'm having radiology or something. That's not my specialty, it's not my area of expertise, and frankly, sometimes, or maybe we have like maybe a professor of English or something that could be very smart, but very unaware of what healthcare is. So don't expect that. That just because they don't understand means that they're low literate. And that low literacy doesn't exist in the United States. It's quite prevalent in the United States. In fact, there's plenty of areas here, and you don't have to go very far to find people who really don't understand. Probably already early on in your nursing education, you've run across people who don't understand healthcare as well as you do, and you're just beginning your journey. Another myth is that they will let us know if they can't read. There's many people who make it to adulthood that do not understand how to read beyond a 6th grade education. And if we're using big words or hand them a lot of forms, they may not be able to understand, and out of embarrassment, they may not tell us. So we'll talk about some of those strategies that we can use to elicit better information from our patients. And beyond being uneducated, we may think that these people are just not intelligent. We'll talk a little bit more about this in class, but there's multiple ways of being intelligent. These people may be expert auto mechanics. I can't fix my car, but that doesn't mean that I'm not literate. It just means, you know, my skills are in different areas. The same with these patients. So in class this week, what we'll be talking about is specifically the Teaching Learning Project. I have kind of a template that we'll be talking about and going through to kind of give you some ideas of what you can put in the various areas. We'll be talking about the sections within there, which would be assessing the patient readiness to learn, planning and preparation, in particular those preferred ways that our patients like to receive information, implementing a plan, and evaluating whether the learner took away from it what we intended. And there's a couple of strategies we'll talk about specifically with teach back technique, which is just the gold standard of making sure that your patient understands what it is that you gave them, and some other strategies that we might use to make sure that our patients adhere to our plans. So thank you so much, and we'll see you in class.